Okay, well, welcome everyone. Tonight's webinar in the Azure Hot Topics series is on buprenorphine, a tool in the toolbox of a pain physician. Thank you all so much for joining us. I am Dr. Lynn Kohan. I am the program director at the University of Virginia, as well as the division chief there. And I'm joined by my esteemed colleague, Dr. Mohammed Issa, who is an expert in the field of pain medicine with unique expertise in psychiatry and addiction medicine. He's dedicated his training and career to the better understanding of the interface between addiction and chronic pain. And his training includes a residency in psychiatry at West Virginia University with one year of chief residency. In addition, addiction fellowship at Yale and his pain fellowship at Brigham, as well as a forensic fellowship at West Virginia University. In addition, he's the current program director of the Pain Fellowship at Brigham and has been in the role for the past 4 years. He also serves as the current medical director of the Pain Clinic and Spine Center at the Brigham and Women's Faulkner Hospital for the past 5 years. It's a very pleasure to have him. I will be serving as both the moderator as well as a speaker. And we want to, at the bottom of your screen, as I'm sure everyone knows by now, but there's the question and answer icon. And please, as we are speaking, feel free to type in questions there. And at the end of the webinar tonight, we will answer your questions in the order that they were received. And so without further ado, Dr. Issa will begin. Thank you.
Thank you, Lynn. And I hope everyone can see the screen and can hear me well. And like Dr. Kohan was saying, if there's any questions or anything, please write them down or write them in the chat, and then we'll answer those at the end. So there's two parts, as you saw before. There's two parts to this presentation. One part is going to be mine, a little bit longer, which is we're going to try and cover buprenorphine as a compound, as an analgesic medication, and some of its properties that we use in the interface between addiction and chronic pain. And then if we have time at the end, I'll do also like a quick case that kind of summarizes everything and gives us an example of what are we talking about in regards to using buprenorphine in these high-risk patients. So thank you all for taking the time today. I know it's 7 o'clock Eastern time, so it's not easy for everyone. This is dinner time, so thank you for postponing dinners, or maybe you're already having your dinner and spending it together. So first we're going to start with the analgesic properties of buprenorphine. And, you know, it has different formulations. Buprenorphine has different formulations. Some of them are approved as analgesics or as pain medications. Others are approved as opioid use disorder. And we'll go again through some of these in detail through the presentation. But the ones approved for analgesia are either given intravenously, transdermally, or buccal. Those approved for substance use disorder, the most common are the sublingual tablets or films, but there are also subcutaneous injectable forms. And buprenorphine as a compound is an extremely powerful analgesic. It is at least 30 to 40 times more potent than morphine over its linear range. As you all know, it's a partial agonist, and the buprenorphine-morphine equivalence at higher doses becomes less certain due to flattening off of the agonist curve. And we'll see that again in some slides as we go through that. Now, due to the different signal transduction pathways, we know that a drug can work as a full agonist on one endpoint and a partial agonist on another. So that designation that we have as a full or partial agonist basically is situational, and it really depends on that endpoint of interest. So the true question is, you know, despite buprenorphine acting as a partial agonist in vitro, does it act as a full agonist in clinical pain settings? And this is a question that we'll try to answer throughout this presentation today. So first, we're going to ask that question of, does buprenorphine work as an analgesic? And this is actually one of the original FDA registration studies that looked at the therapeutic efficacy of buprenorphine as an analgesic. And it's a randomized, double-blind, placebo-controlled, multi-center study, all these things that we look in a good study. And it included patients that had chronic severe pain related to cancer or other diseases that were inadequately controlled with opioids. So as we kind of think about it in the medical field, or, we say those difficult patients that you just don't know what to do. And they were randomized to receive buprenorphine transdermal, either at 35 microgram, 52 microgram, or 70 microgram per hour patches, or placebo. And as you can see, these dosages are a little bit higher than what's already approved here in the US, which is, from 5 to 20 microgram. But again, it gives you an idea of how this medication works and its effectiveness. Patients were permitted throughout the study to use some rescue sublingual buprenorphine, so nothing else but just buprenorphine, but sublingual form. And it's a small dose, just 0.2 milligrams, to see if that will help with breakthrough pain. 157 patients were enrolled in the study, and what they found was that the transdermal buprenorphine was showed significantly higher response rates than placebo in all different dosages. The only one, interestingly, that they found no statistical significance was the highest, which is the 70, but all of the others were statistically significant as well, both clinically and statistically significant. The reduction in pain was about 60%. And the dosage, the sublingual analgesic dose that they used, was minimal. So the patch by itself did most of the job. And that 60% reduction in pain was compared to about 8% reduction with the placebo. There is a huge difference. Again, these are patients that had high levels of pain, mostly either, more than not were cancer pain patients that were on high doses of opioids prior to that. So, and out of those, about half of those patients, they reported good, or what they reported as complete pain relief. So again, at least half had reported really good pain relief. Minimal side effects were reported. So then comes the question after that of, okay, so if it did work as an analgesic, and there's multiple other studies that confirmed that, how about the second question of, is it long-term? Is this effect of analgesia for buprenorphine lasts for a long period of time, or does it fade away with time? And this study is actually an extension of the previous FDA study that we looked at, looking primarily at the durability of the analgesic effect. It was an open label, uncontrolled follow-up study for patients who elected to continue treatment with transdermal buprenorphine, and it was mostly the 35 microgram patch. They had visits every 2 weeks for the first 4 weeks, and then every 4 weeks for the remainder of the study. About 239 patients were enrolled in it. Most of them were cancer pain patients, and the mean duration where they stayed in the study was close to about 8 months. So it's a long duration of time. Some of them were even up to 5 years. And then what they found in this study is about 80% of these patients actually stayed with the therapy, which is a really good thing, because we don't see that level of adherence in a lot of other therapies that we do. Now, the majority of patients, about 66%, so about 2/3 of patients, managed their pain with just the patch, or maybe took one additional sublingual dose for breakthrough pain. And 90% of them reported what was mentioned as satisfactory pain relief. And usually the definition of satisfactory pain relief is 30% or more, but for the patients, they did feel that that was enough to control their pain. Of course, the one drawback or one potential criticism is that there's a selection bias in this, because patients who already were doing well are the ones who continued the study. But again, it shows you that if patients do well on the medication on buprenorphine as an analgesic, they are more likely than not to stay on this form of therapy. Up to 80% of them stayed, and they continued reporting that good analgesic effect until the end. So again, that's the second question, long-term efficacy. It is present. Third question is, is it as good as other opioids? And that's an important question. Does this medication work the same as other opioids? Now, you'll see here two studies. On the left side, this is a study by Rafa that looked at the analgesic effect of intramuscular buprenorphine. It was a dosage of 0.3 milligrams compared to intramuscular morphine, 10 milligrams. And it was used for post-operative pain, same thing in a randomized double-blind, multi-dose, non-crossover trial. And it included about 60 patients that underwent upper abdominal surgery. The post-operative pain intensity was measured prior to the first dose of the drug and then every 15 minutes, up to 2 hours. And then after that, it was extended to every hour. So they measured it closely, as you can see there. And what they found was that the morphine and buprenorphine produced similar decrease. And you can see from the graphs, similar decrease in pain intensity. So it was similar to morphine in its efficacy and its strength. On the right side, this is another study by Edge that included more patients, 101 patients. Here it compared sublingual buprenorphine, 0.4 milligrams, to intramuscular morphine. So here are the sublingual to intramuscular. Same thing, randomized double-blind study, post-op pain. And here it found that buprenorphine produced the same pain relief as morphine during the first 2 hours. Interestingly, after 2 hours, it was even a modestly greater pain relief from 2 to 6 hours. So it even worked better than morphine after the first 2 hours. So really, is that for real? Yes, really. I mean, on the right side here, you can see another study by Rafa that included 79 patients, and it compared the analgesic effect of patient-controlled analgesia. So PCA buprenorphine was compared to PCA fentanyl in patients recovering from elective thoracotomy. And as you can see again, same thing, buprenorphine was equivalent in its efficacy with fentanyl throughout 24 hours post-op. On the left side, the analgesic efficacy of intravenous buprenorphine at dosages of 1.5 and 3 were compared to intravenous morphine at dosages of 50 and 100 microgram per kilogram. Same thing, post-operative pain. Difference is that this is actually children, 0 to 6 years, recovering from lateral thoracotomy. Now, post-operatively, the patients received increments of buprenorphine or morphine every 5 to 15 minutes until the patient reported the pain score of 0 or 1 for more than 15 minutes. What they found again was that the higher dosages of buprenorphine and morphine both produced a pain-free response. If anything, the buprenorphine actually produced the pain-free response slightly quicker than morphine did. So again, and more studies kind of confirm that phenomenon of how buprenorphine compared to a lot of other opioids equivalent to them, or sometimes even better. Now, this is a question that I think it's really important clinically as well, because I get it all the time from my residents and fellows asking, so how, we have all these different formulations, and one of the common formulations we use for analgesia is the transdermal buprenorphine. How do you compare that to sublingual buprenorphine? So the highest dose of transdermal buprenorphine available, which is 20 microgram per hour, is equivalent to which of these dosages? Is it the 0.6? Is it the 1.6? Is it the 5.7, the 6.3, and 11.4? I want you to think about it. Now, unfortunately, we don't have this open up for answers, but maybe if anyone wants to put in the chat what you think the right answer is of these 5. So I have D. I have one answer says D. Anyone else? A, B. Great. So we have A, B, D. There's only C and E left, but I'll make it easier. It's actually B. That's the right answer. So basically, there are three main dosages that we use with transdermal buprenorphine. We have the 5, the 10, and the 20. There's also 7.5, but that's not available in a lot of places. But the 5 microgram is equivalent to 0.6, the 10 microgram is equivalent to 0.8, and the 20 microgram is equivalent to 1.6 milligram. So remember, for the sublingual buprenorphine that we use for addiction purposes, the lowest dose is 2 milligrams. So that gives you an idea of where we start with this and where we end with the other. So the end of the transdermal buprenorphine is equivalent or even slightly lower than where we start for addiction purposes. And we'll talk about this a little bit later on about the significance of analgesia versus addiction and how the brain and spinal cord understands that. So again, we kind of mentioned that briefly when we started, the different forms of buprenorphine. There's the injectable, the buccal film, and transdermal. The injectable is called Buprenex, and it comes in 0.3 milligram dosage IV, 0.3 to 0.6 intramuscular. The buccal form is called Belbuca. That was the most recently approved in 2015. And that one is given twice a day. You put it on the inside of the cheek, you let it dissolve. There's two sides to it, the yellow and the white. And, there's really, I always tell patients, just so that you don't get confused, there's really good instructions on the pamphlet telling you how to apply it. You have to leave it there until it completely dissolves, which side is on the inside and outside. But it starts with 75 micrograms and goes up to 900 micrograms twice daily. And then there's the transdermal form, which is the Butrans patch that we talked about. And we said it goes between 5 to 20, but the most common forms are the 5, 10, 15, and 20. We usually start with 5 in an opioid naive. I start with 10 in an opioid tolerant patient. Sometimes I'll start on a higher dose, but very rarely. It's usually my starting dose is 5 to 10. The Belbuca is the same thing. You start at 75. If opioid naive, I start at 150. It's opioid tolerant. And the bioavailability, as you can see, of course, the injectable is 100%, but the buccal film is about 50% or so, and the transdermal, it's only 15%. So then, what we've seen so far, we answered the questions of, does it work as an analgesic? Does it have durability and long efficacy? And how is it compared to other opioids? Now comes the question of, what about a higher dose? Is a higher dose associated with better pain relief or not? Now, to the left, you can see here, this is a case report of a terminally ill pancreatic cancer patient with kidney and liver failure. So really sick patient suffering from severe pain, 10 out of 10 on a daily basis. Buprenorphine was given intravenously and transdermally while in the hospital with increasing dosages over 15 days. And you can see that the patient, by the end of 15 days, pain level went down from 15 down to 2. So yes, a higher dose, as you went up on the dosage, is a higher dose, we saw improvement in pain levels. To the right side, this was an informative study of 50 patients who underwent elective C-section. And again, intravenous buprenorphine was given post-op and the dose was titrated against the response of each patient. Now, as you can see from the graph, that it was a dose-related effect. 100% of the patients had complete pain relief at the end as the doses went up. So again, answers the question that as the dose of buprenorphine increases, we can get improved pain relief. Now, I'm including this study just to show, or this slide just to show, other studies. It's not just confined to the, to the 4 or 5 studies that I mentioned, but there's many other studies out there that show the efficacy, durability, safety, and long-term effect of buprenorphine, many, many more, including systematic reviews. So then comes the other part of, the other question, the other big question is, what about patients who are already on opioids, not opioid naive patients? And those are the patients that, you have found so far, for those who have already done, their fellowships or, they're in residency and waiting to start their fellowship is, these are some of the really difficult patients. What do you do with them? They are already high doses of opioids. Do you think about opioid rotation? You're worried about opioid tolerance. Where do you start them? You're worried about side effects. You're worried about sedation. You're worried about respiratory depression. You're worried about all these different things. They don't respond too well to even non-opioid regimens when they're on these high doses with hyperalgesia and all these other things happening. So is buprenorphine a good choice for these patients or not? So here, this is a study that actually looked at chronic pain patients that were converted from full agonist opioids to buprenorphine. And here the average or the mean daily pre-induction dose was about 180 morphine milliequivalent. So again, it's a high dose. These patients are on high doses of opioids. It was an observational report that was designed to determine the effectiveness of converting patients from traditional full agonist opioids to sublingual buprenorphine. And there was about 104 chronic pain patients involved in this study. They were previously treated with, again, opioid agonist drugs and converted to sublingual buprenorphine, and they monitored them for 2 months and above. What they found was that after initiation at about 2 months, and usually we try to monitor things, at 2 months and above, just because it takes time for patients to adapt to a new medication, to adapt to the new dosage. There's a lot of things that buprenorphine, and we'll talk about how buprenorphine works, but there's a lot of things that buprenorphine does in reversing the hyperalgesia, reversing the tolerance, reversing a lot of things that these full agonist opioids do. But also at the same time, we start at a low dose and kind of build it up. So it takes time. So it's always, you'll find that a lot of these studies that look at conversion, they try to look at more of a longer term, at least 8 weeks and above. What they found that, at the 2 month period, the mean pain scores, they dropped or were decreased by about 2.3 points. So again, these are patients that are maintained on full agonist opioids, high dose full agonist opioids. When they were converted to buprenorphine, there was a decrease in their pain by an average of 2.3 points. Now, what they found was that it was actually dependent also on the type of drug. So the success rate was highest with patients using morphine, oxycodone, and fentanyl. The highest was with patients that were on morphine. The decrease in pain level was about 3.7 points. Then followed by those on oxycodone was 2.5 points. And then followed by fentanyl was 2.2 point decrease. The smallest pain decrease, as you can see, was the oxymorphone, was only 1.1 points. In addition to the type of drug, there was also variability dependent on the dosages. And as you would guess, the patients with lower dose did better than patients with higher dose. So patients that were taking about 200 to 300 milligrams of morphine equivalent, they had the most decrease, about 2 points and above. Those with more than 400 morphine milliequivalent, they did less. So it was about a 1.1 point decrease. Now, this is also another retrospective chart review study that looked at 35 chronic pain patients, but were on even a much higher dose of morphine. These patients were up to 1,370 morphine milliequivalent, huge dosages of opioids prior to conversion to buprenorphine. The mean daily dose here was 550. And basically it showed very similar results. After continuation of sublingual buprenorphine for 2 months and above, they found a decrease in pain level went down from an average of 7.2 to 3.5. So that's kind of a really significant decrease in pain levels. And as you know from pain patients, living at a 3 or 4 pain level, this is really their dream. They found that the pain score decrease was robust with regards to initial pain score and pre-conversion morphine equivalent dosages. So again, the lower the dose of the morphine, they found that they actually did better than those super high doses. But also, in addition to the decrease in pain level, there was also an improvement in the quality of life. And quality of life scores, and those improved from 6.1 to 7.1. This is, again, another study that looked at the efficacy of buprenorphine as an analgesic in cancer pain patients, where historically they use high-dose opioids. And opioid-tolerant patients here were on a dosage of about 90 to 150 morphine milliequivalent, and they were switched to transdermal buprenorphine at a dosage of 70 microgram per hour. And the group was then divided into continued transdermal buprenorphine versus placebo. What you can see here again from the graphs is that patients on transdermal buprenorphine, they did significantly better than placebo. So the active treatment group, it actually did better in this cancer pain population. I included this study, and it's kind of, it's a little bit small, the slide. I don't know if you can see it, but it's kind of a small study that only included 21 patients. But why I included it here is because it kind of showed in a nice way how they converted patients from high dose from high dose opioids to buprenorphine. And the main idea, and this is basically what we do clinically too, is the main idea is you want to try and convert them from, if they're on a combination of long acting and short acting, combine it together into a short acting and then stop the short acting opioid. Somewhere we used to say 24 hours. Now we've decreased it to about 12 hours or less. And then we talk to them about withdrawal symptoms and what they expect with withdrawal symptoms. So if they start experiencing withdrawal symptoms, then we can start the induction. We used to do in-office inductions. Now a lot of the inductions are done as home inductions. And there's really a lot of research looked at it, and they found no difference. If anything, most patients prefer to be at the comfort of their homes when they do these inductions. And basically, once a patient goes into withdrawals, they start with a 2 milligram dosage of buprenorphine sublingually and see how they do. If they do well with it, then that's it. You monitor them, maybe give another 2 milligrams at bedtime, and then the next day you do 2 milligrams 3 times a day, because the analgesic effect of buprenorphine usually does not last more than 8 hours or so. If you give them the first dose of 2 milligrams, but they're still having withdrawal symptoms, then within an hour to 2 hours, you can give another 2 milligrams. So that's a total of 4 milligrams. If it takes care of the withdrawal symptoms at that time, then 4 milligram is my dosage. I give it again at nighttime. And then the next day I do 4 milligram 3 times a day, have, some rescue 2 milligrams if they need to, and you can adjust the dose depending on that. Same thing, if 4 milligrams didn't do the trick, you add another 2 milligrams in an hour. So that's a total of 6 milligrams. You take that 6 milligrams, you give it again at nighttime, and then you divide it. In this study, they went up on the dosage up to even 24 milligrams. Truthfully, clinically, I usually try not to give more than 12 to 16 milligrams the first day. Second day, I can increase the dose. But again, it can be safe to do up to 24 milligrams. But I'll tell you, most addiction specialists, since we use high doses of buprenorphine, they'll tell you that they usually try to limit it to 12 to 16 milligrams the first day. So, of course, comes the question of, what makes buprenorphine special? And what we know about it already is that it's a partial agonist of the mu receptor. It's an antagonist of the kappa receptor, but there's actually much more to it than that. At the morphine opioid receptor, it activates a different subset of the G protein that classic opioids such as the fentanyl, morphine, and methadone. So it has that G protein activation much more than what you see with full agonist opioids. Also, there is the opioid receptor like 1 agonist effect or activation, and that produces analgesia at the level of the dorsal horn, reduces tolerance to opioids in the cortex. Remember when we talked about some of its effects is even reversing that tolerance that we see with the full agonist opioids, and that's through the ORL1 activation. Buprenorphine has a therapeutic window more than 10 times that of fentanyl, so that that kind of plays a role in the significant safety benefit that we know of it in regards to the ceiling effect on respiratory and CNS depression. And when administered together with a traditional mu agonist, buprenorphine antagonizes what we call the beta-arrestin activity, which explains why morphine-induced receptor phosphorylation and desensitization is blocked when administered with buprenorphine. So basically what it does is this effect, this beta-arrestin effect, it accounts for that super additive effects when combining full agonist opioids with low-dose buprenorphine, which is really, this is kind of a new type of thinking that we think about the compound of buprenorphine. In the past, we always thought about buprenorphine as you either do that or you do a full agonist opiate because they can antagonize each other. But actually, there is an additive effect of a low-dose buprenorphine with even full agonist opioids because of that. And then the last part is the antinociceptive effect of buprenorphine at the naloxone and the naloxone sensitivity and insensitivity. And this is a really interesting phenomenon. So as we know, antinociception, it means inhibition of the sensation of pain. And you can see here, there's two pain models. The acetylcholine-induced abdominal irritant test and the water tail immersion flick test. And what we found was that when buprenorphine was administered subcutaneously, as you can see here, all three drugs, buprenorphine, morphine, and fentanyl, they induced a dose-related antinociception. It reached about 100%, you can see on the left side here in both tests. But on the right side, you see the classic biphasic. We call it the biphasic dose-response curve of buprenorphine, which means that the maximum effect, the maximum positive effect, which is the MPE, goes up, until the dosage is about 10 milligram per kilogram, and then you see the effect going down. And we call that classic biphasic dose response. And this is not classic for just buprenorphine. We see it with many drugs that you can see that biphasic response. And this again, goes to the effect of what we call, how is buprenorphine as an analgesic and how it's used in as an addiction drug. And as an analgesic, there's controversy about as you go up on the dosage, do we see decreased analgesia with super high doses? As an addiction drug, the effect may continue increasing. But truthfully, other than the animal studies, clinical studies have shown that as the dosage go up, and I shared a few studies earlier too that showed that the effect possibly increased rather than decrease. So there's still a lot to learn more about that antinociceptive effect of buprenorphine. The second part that's also interesting about this compound is how it works. So we know that it works not just on the spinal cord, but it works also on the brain. And what they found was that the analgesia of buprenorphine is, of course, largely mediated through the mu receptors in the dorsal horn. There is a supraspinal site, but that is not fully blocked by naloxone. So on the left side, you have the intrathecal buprenorphine that was injected. As compared to other drugs as well, you have morphine and fentanyl, and all of them were blocked by naloxone. On the right side, when it's injected into the ventricles, you find that the naloxone effect on morphine and fentanyl is reversed, but not for buprenorphine, which tells you that patients who overdose on buprenorphine, we have to be extremely careful because you can reverse the intrathecal effect of it, but you cannot reverse the brain effect, the intraventricular effect of it. Again, another quick question: which test is classically used in human research to investigate opioid-induced hyperalgesia? Again, if you want to put it in the chat, is it acupuncture? Is it the FACES pain scale? Is it the hot plate test, the cold pressor test, or the functional magnetic resonance? And I have one saying it is the functional magnetic MRI. And the cold pressor test is the second answer. And yes, I've had a few saying that, and this is true. It is the cold pressor test is what we use to investigate opioid-induced hyperalgesia. Now we're going to end this with these, interesting slides about functional MRI and receptor occupancy. So the first slide is looking at, and this is data that was back from 2003 by a study by Greenwald, and I think it's a really neat figure because it makes you think about this, makes this figure stick in your mind when you think about buprenorphine and opioid occupancy or mu-opioid occupancy. So this was a heroin-dependent volunteer maintained on buprenorphine at different dosages. First, of course, you can see there's nothing at all, buprenorphine 0, then 2 milligrams, 16 milligrams, 32 milligrams. You can see that the buprenorphine 0, there is blue areas at the end there at the occipital area. And this is basically because in the occipital region, there is no mu-opioid receptors. So the images were scaled so that the binding in the opioid receptor, which is devoid of the mu receptors, is equal to 1. And then they looked at the other areas where there are mu-opioid receptors. And you can see as the dose increases, the occupancy of the mu receptors increase as well. Interestingly, what they found was that changes in the mu-opioid receptor availability varied according to the dosage. So for example, at 2 milligrams, they found that there was more availability in the prefrontal cortex, 47%, as compared to the amygdala, for example, 27%. But as the dosage increased, they found that it was more homogeneous. You can see that everything is turning bluish to purplish. So as the dose increases, the availability, the mu-opioid availability decreases. The lower dosage, there's variability in these different availabilities. As you increase the dose, it becomes more homogeneous. What about if we stop it? If we stop the buprenorphine, what happens with the availability of the opioids? And this is again another study that looked at this or helped answer that specific question. So basically, you can see again, after stopping buprenorphine, post 4 hours, post 28 hours, post 52 hours, and post 76 hours. So at 4 hours, 30% of the receptors were available, 28 hours, 54%, 52 hours, 67%, and 76 hours, 82%. The interesting part, why I think this is extremely important, because it answers that question that we have about, how long do we wait after stopping buprenorphine before a patient goes into surgery or to give full agonist opioids or things like that. And you can see at about 1 day, 24 hours, about 50% of the receptors are available. We used to say wait for three to 5 days, which, to kind of make all the receptors available, but we found that this is really not necessary. And now even a lot of guidelines, and Dr. Kohan is going to talk about this, a lot of guidelines have even shifted towards now more of, if it's a minor surgery or a surgery that doesn't require a lot of opioids or doesn't require post-op, like prolonged post-op care, there's a lot of surgeons and anesthesiologists that will even say, you don't even need to stop it. You just decrease the dose. I just need 25, 30% of my opioid receptors available, and that's enough for me to work with the drugs I need. And we found that patients actually do much better that way, because transition from buprenorphine to the opioids given, during surgery, after surgery is much easier, but also more importantly, transition after that, to go from that into back again to the buprenorphine has become much, much easier. And only 50% of the receptors are needed to suppress withdrawals. So the last slide is that question I talked about, and I'll go through it real quick. So this is a 52-year-old female with, depression, anxiety, tobacco use, interstitial cystitis, chronic pelvic pain that has been on long-acting opioids for 20 years, was referred to addiction psychiatry by her PCP to assess appropriateness of opioid regimen and concerns for requests of increased dosage. She's been on OxyContin 50 milligram 3 times a day, oxycodone 10 milligram every 4 hours, so high doses, about 300 morphine milliequivalent, as well as other non-opioid medications. Says that her pain is always at an 8 or a 9 out of 10. She says, this is what I have to live with. I know that, my doctor doesn't want to increase the dosage. There were some concerns about aberrant behaviors, asked for higher dosages sometimes. On 2 occasions in the past, she ran out of oxycodone early because she was taking more than prescribed because of a pain flare-up. But she's been in the practice for 10 years. All urine toxicology screens have been appropriate. So, one of those classic patients that it's not a full-blown opioid use disorder, but at the same time, they're basically on these high dose of opioids that are just not doing too well. And the thought was, let's switch her to buprenorphine. So basically, what we did for her is we first thing is decrease the dosage. So the OxyContin, we switched it to oxycodone, and we decreased the dose up to 200 morphine milliequivalent. Then you changed all the opioids to the IR form, discussed the induction process with the patient, of course, provided clear information on how to do home inductions. And again, like I said, there is really no much advantage between home and office inductions. So most of the inductions we do now are home inductions. And we started buprenorphine, like we talked about, with a lower dosage, and then increased the dose during the first day until we came to a dose that helped with the withdrawal symptoms. And then we divided that over 6 to 8 hours throughout, and she did extremely well after. Last thing is, what are some of the barriers that we have for sublingual buprenorphine for pain? Of course, the requirements for X waiver, although now there are, these requirements have been waived for most physicians, and most physicians even can prescribe buprenorphine without the X waiver, but it's only limited to 30 patients. Limited support and consensus for off-label use of buprenorphine for pain, stigma, limited physician education, limited understanding amongst providers. But again, this is why we're doing these talks, to improve the understanding of physicians about this and feeling more comfortable prescribing this medication, so we can make the impossible possible. And these are some of the references for what we talked about today. So I will stop here, and I will turn this to Dr. Kohan.
Great, thank you. And I will share my screen. Okay, just okay. So we're going to switch gears a little bit and just talk a little bit more about buprenorphine in the perioperative period. And so why is this even important? So more and more people are being unfortunately afflicted by opioid use disorder or substance use disorder. So kind of looking at some of the statistics, and this is from 2018, you can see they're really pretty staggering. And this number here, people who died from overdosing on opioids, this has even essentially doubled since this time. So the most recent data has shown over 100,000 people have died from opioid overdosing in the past year. More and more people are using heroin for the first time. A lot of people have misused prescription drugs. So we're going to encounter these patients as pain physicians and within the perioperative period. And so it's really important to understand this. We can see here too, the numbers have really been going up. There was a brief period of time, kind of a little bit like right before the COVID epidemic, where kind of had a leveling off. But since the COVID epidemic, it's really increased even more exponentially. And so, what is the impact of this? The overdose and death can occur from misuse of opioids or opioid use disorder. People can get infections. There increased risk for having comorbidities, economic loss, really a lot of family disturbances and destruction, and legal issues. And again, we've seen how these numbers can really go up. And then again, within the COVID epidemic, more and more people, they've done surveys for people secondary to emotional stress from social isolation or the economic stress, have reported using substances more than they had in the past, trying substances they hadn't tried before for their first time. And this is probably contributing to the unfortunate circumstances of opioid use disorder and the skyrocketing of opioid overdose deaths. So what is substance use disorder? So the DSM-5 criteria kind of breaks it down into different categories. So impaired control. So you're taking the substance, in larger amounts of time for longer periods of time than was intended. Desire, persistent desire, or you cannot cut down. So you want to cut down, but you no longer have that control. You continue to use despite your best efforts. And you're really spending all this time figuring out how are you going to obtain the substance, in this case opioids, in order to have that effect. And really there's those cravings and strong urges to use. There's also social impairment. So you're basically experiencing problems at work, at school, at home, and you know this, but you still aren't stopping, and as well as interpersonal problems. And then risky use. So you're using despite the fact that you're getting into hazardous situations, and continued using the substance despite having persistent recurrent physical or psychological problems that are being worsened because you're using that substance. And then the pharmacological criteria. So symptoms of tolerance, so reducing effort with increasing doses, and then signs of withdrawal if you were to stop the substance. And this can be broken down into mild, moderate, or severe, kind of depending on how many of these criteria that you meet. It's also important to understand that approximately 10 to 30% of hospitalized patients have a non-alcohol related substance use disorder, and that almost 40% of these might not be recognized by the care team. And that's why it's important that we recognize it, because we might have a chance to intervene when otherwise the disorder would have gone unnoticed. Not receiving care. Most of the patients might not be receiving care anywhere else for their substance use disorders. So this is, for many reasons, people might feel stigmatized, afraid to seek help, not being ready to seek help. But even those who want help, there's such not enough treating physicians. So it's really hard sometimes for people to seek help, especially in rural or underserved areas. In addition, so almost a third of patients who have a substance use disorder in the hospital might leave AMA, which of course can complicate the hospital course. In addition, patients with substance use disorders have poor adherence to the treatment plan. They could be undergoing withdrawal, which might complicate their recovery, their post-surgical recovery. Can have prolonged lengths of stay because of some of these problems. And in general, they have poor outcomes. So where does buprenorphine come in? So I'm not going to go into all the specifics because Dr. Issa already did a good job of talking about some of the basic pharmacology. But in general, as we know, it can reduce opioid withdrawal and cravings. It has that high binding affinity for the mu-opioid receptor. And so this is where sometimes some misconceptions come in, because it can potentially displace other full mu agonists, and it can potentially precipitate withdrawal. Because once in place, since it binds tightly, it may prevent additional binding. But as Dr. Issa talked about, and we'll mention again briefly, that doesn't mean that there's other receptors that are not available. An advantage of buprenorphine over some of the other FDA-approved medicines for the treatment of opioid use disorder is that it does not require daily trips to the clinic, like typically of most methadone clinics. It's also okay for use in the elderly and those with hepatic and renal insufficiency, unless it's severe. So it's generally safer. In addition, as Dr. Issa talked about, it's safer from a respiratory standpoint as well. So it's safe. Other important aspects is that to understand in hospitalized patients is that the first 28 hours after discharge, when opioid use disorder related problem is the most vulnerable time. This is when most opioid overdoses occur. So first month out of discharge, more patients are more likely to die. And patients who actually get treated with a medication for opioid use disorder have mortality rates that are lower. So not quite as low as the general population, but death rates for patients who have no treatment are much, much higher than patients who are receiving medication for opioid use disorder treatment. So buprenorphine can help save lives, especially during that vulnerable period after that first month of discharge. So it's life-saving. The number needed to treat to prevent one death from opioid use disorder is actually less than 3. And this is actually really a important number. So many of the medicines we use just say for treatment of pain, the number needed to treat are generally much higher. So this is pretty substantial. Buprenorphine treatment was associated with a 30% reduction in all-cause mortality during the first year after a non-fatal overdose. So it's actually rare to have this like amazing ability to help save lives, and that's what buprenorphine can potentially do. So we already talked some about the formulations. And so just as a reminder, in general, when you're talking about formulations, the milligram doses are going to be the formulations that are FDA approved for opioid use disorder. For microgram doses are the ones that are approved for pain. And so that kind of brings us, I just wanted to thank the other members of the multi-society working group who worked on the guidance and the recommendations in the document. And so there's kind of two thoughts, right? When you're in the perioperative period, what to do? Do you continue buprenorphine maintenance therapy for patients who are actually in treatment and are already receiving buprenorphine for medication for opioid use disorder, or do you stop it? And so the fear is that discontinuing it exposes patients to the substance of addiction and may lead to relapse. And so there's fear, stopping it can actually cause harm. But some people might argue, well, if I continue it, I'm not going to be able to control their pain. Right? They're going to be out of control, and what can I do then? But as we've talked about, as Dr. Issa talked about, that's not necessarily true. So yes, buprenorphine does bind with a higher affinity than other opioids. We know that, but we've seen the binding studies, and so I didn't include all the same graphics about the functional MRI, but as you can see, buprenorphine, as he talked about, even though it's binding to those receptors strongly, there are still receptor availability. So it doesn't, especially at doses that buprenorphine is typically prescribed at for the treatment of opioid use disorder. So in general, patients can be fairly well controlled for their opioid use disorder at doses of 16 milligrams. And that 16 milligrams, even after just 4 hours since your last dose, there's still receptors that are available for other full mu agonists to bind. And then also it's important to understand that, as Dr. Issa also talked about, that buprenorphine in itself can be an effective analgesic. And so what were the recommendations? So in terms of the preoperative plan is that it was a grade B, moderate level of certainty. So buprenorphine should really not be routinely discontinued. So regardless of the type of surgery, if it's a minor surgery, a moderate type of surgery, a major type of surgery, it should really not just routinely be discontinued during that time. Discontinuing buprenorphine in patients with OUD actually can increase the risk of relapse or harm. And the home dose of buprenorphine should not be routinely tapered prior to surgery in most cases. And so recommendations, so again, just regardless of the type of surgery, elective, urgent, or emergent, the recommendation is that buprenorphine home dose should not be routinely discontinued or tapered. So for how can you manage them? So in terms of the buprenorphine itself, the buprenorphine potentially can actually be split into BID or TID dosing in order to provide that analgesic effect. So yes, it has that long half-life, but the analgesic effect is shorter than the half-life. And so therefore, by just splitting it into doses, you can optimize the analgesia from the buprenorphine itself to help treat the patient. For severe pain, the home dose again can be split into TID dosing to help improve the analgesic effect. In addition, potentially you can think about increasing the buprenorphine in order to obtain better pain control, or to use IV buprenorphine if that formulation is available. And then of course, we recommend close monitoring with pulse ox if possible. And then acute pain with other opioids, you can maximize non-opioid strategies. So treating acute pain with high affinity additional opioids for patients, and avoiding the potential drug that the patient misused in the past. But potentially fentanyl derivatives and hydromorphone are most likely to have a higher effect because they have higher receptor affinity than other opioids. And then again, close monitoring. And then of course, try to maximize the non-opioid pharmacological management. So regional techniques, local infiltration by the surgical team, intraoperative or postoperative ketamine, lidocaine or magnesium infusions, dexmedetomidine if that's available, topicals, NSAIDs, acetaminophen, and then anti-neuropathic agents or antidepressants and muscle relaxants as deemed appropriate. And then non-pharmacological management, ICE, position change, use things like relaxation strategies, mindfulness, peer recovery support, and distraction techniques. And then in the post-op for disposition, in the PACU, use appropriate, use these methods that we just talked about appropriately, and discharge home if the patient's pain is satisfactorily controlled, but continuing coordinating the buprenorphine dosing plan with the buprenorphine prescriber. Inpatient floor admission, of course, if the patient's being admitted or there's other issues, and then consider ICU admission if there's concern that there might be respiratory concerns. So for the post-operative pain plan, grade B, a moderate level of certainty, is utilize multimodal analgesics in patients receiving buprenorphine for MOUD, and consider the administration of short-acting full mu agonists with close monitoring if the pain is still uncontrolled, or if the multimodal analgesia is inadequate. And then grade C, a low level certainty, consider increasing and or dividing doses of buprenorphine with close monitoring for uncontrolled pain if or when multimodal analgesia is inadequate. Discharge planning, a grade A, a moderate level certainty, is to provide post-operative plan to taper off the full mu agonist or return to the preoperative maintenance dose of buprenorphine. So it's important to, to make sure patients understand that if you had to give full mu agonists, you want to have a specific plan to taper them back down. If you had to go up on the buprenorphine, you want to have a specific plan to taper them back down to their maintenance dose instead of just continuing at these higher doses indefinitely. And it's extremely important to collaborate and discuss the plan with the patient's outpatient opioid prescriber, so their buprenorphine prescriber. But that was for patients who are already in recovery. They're motivated to stay better often. But what about patients who are not on buprenorphine, who may have an untreated disorder or you suspect have an untreated disorder? This is an important time where you can potentially consider starting buprenorphine in the hospital. And why is that? So patients might actually be more ready to change, right? They're in the hospital for some problem. So they start to think more, they might recognize that they have a problem. They may be more ready to change. They also might come to the realization that this disorder is impacting their relations with their family and their friends. They might have been in the hospital and being so forced this abstinence. So that might have allowed them time to consider a change. And hopefully they're surrounded by a non-judgmental care team that make them more willing to seek treatment. So is there evidence? So can buprenorphine be started safely in hospitalized patients? And the answer is yes. There's been evidence that it can be started in hospitalized patients and that doing so actually improves the chances of longer-term recovery. So studies have shown that there's been lower rates of illicit opioid use at 6 months follow-up period among hospitalized patients who had been initiated on buprenorphine and linked to buprenorphine treatment upon discharge. The hospital patients who were initiated in the hospital versus patients who were detoxed resulted in greater long-term use of MOUD upon discharge. And so you might be thinking, why me? Like, why do I don't like to talk to my patients about this? Like, this is, really not a pain physician or anesthesiologist job to do it. But really, there's other specialties that are doing this now too. So emergency medicine have some cases have changed their clinical policy to say that, we need to be starting this in patients who are presenting to the emergency room with a substance use disorder or opioid use disorder. So a slide just to show you that this can be successfully done. So patients who are presenting are started and initiated on buprenorphine. There's many studies to show that this can be done. It's even being done in some circumstances by EMS, so in the field. So they're coming upon a patient and the EMS is allowed to actually administer buprenorphine and then aid them in linkage to treatment. In addition, the National Academy of Medicine is making this a priority for evidence-based treatment of opioid use disorders, so strategies and to remove barriers. And part of that is to essentially ensure that all physicians to obtain or retain your license has some kind of buprenorphine training. So starting in medical school and then again to renew your DEA license requirement. So how can this be done? So there is a lot of evidence from the emergency medicine literature where they're essentially starting buprenorphine at even 4 to 8 milligrams, and that even at these doses that can be safe. But important to remember that buprenorphine is not naloxone, so it's not a full, it's not an antagonist. You're not going to be dropping patients from here all the way down to here. So if you can initiate it at lower doses, you can kind of drop them stepwise so they don't have to experience withdrawal. In the past, it was always thought, your patient had to be in withdrawal before starting buprenorphine, but that's not necessarily true. You can start at these lower doses without having to precipitate withdrawal, which is what patients are afraid of. They don't want to start buprenorphine because they don't want to feel withdrawal. But the reality is they don't necessarily have to in order to safely initiate buprenorphine. So what were our recommendations? And so, talk to your patients. If you're coming, consulted for post-op pain on the acute pain service, you can actually talk to the patient and you suspect the patient has an opioid use disorder. See what their interest is. They might not have an interest in the beginning, but if you talk to them in a non-judgmental way, they might be willing to try. Make sure there's no contraindication. So obviously that's some kind of allergy to buprenorphine or naloxone if it's a combined product. Severe liver dysfunction or active intoxication with other types of CNS depressants, or of course patient refusal. But if the patient is willing and they're on the IV PCA opioid, can really hold the IV PCA for about 1 to 3 hours. If they're on oral opioids, then you can hold it essentially from their last dose. If they're getting oxycodone every 4 hours, instead of giving the oxycodone at the 4 hours when it's due, this is the time where you can potentially give the buprenorphine. So you start at 2 milligrams of buprenorphine, the 0.5 of naloxone, and see how you do. You can wait 1 hour and reassess. You can use the SOWS or the COWS scale to assess for withdrawal. And then essentially every 1 to 2 hours, you can give another 2 milligrams of the buprenorphine up to usually about 8 milligrams on the first day. And then on the second day, potentially getting up to 8 milligrams BID if needed to help both with analgesia as well as the opioid use disorder. Of course, during this time, you can also consider using multimodals if they're available. Ketamine, lidocaine infusions can be helpful. And then for discharge, if possible, link to an addiction medicine specialist or treatment facility. This is just an example of the clinical opioid withdrawal scale called COWS that you can use to kind of assess their level of withdrawal. So essentially you can kind of give them those 2 milligrams of buprenorphine to ensure that they're not going into withdrawal and until their pain is controlled. So what were the recommendations? So starting buprenorphine in patients with suspected MOUD. So grade B, moderate level of certainty. When possible, anesthesiologists or pain physicians can consider starting buprenorphine for post-op analgesia in patients with suspected OUD. They should also help, if possible, facilitate linkage to outpatient buprenorphine prescribers. Now, we recognize that that part might be hard. We just talked about earlier, there aren't enough prescribers. So even if there's not a prescriber, it's still probably better to potentially start them on buprenorphine even if there's no linkage, then to start, not do that at all and just send them home with oxycodone or Dilaudid. This is a grade C lower level of certainty, but still probably better than the alternatives. It is also our group's consensus to continue to fight for eliminating barriers to prescribing, and then also to advocate physicians obtain education and X-waiver certification. And so in summary, and we're going to talk a little bit more about the X-waiver in a second, but opioid use disorder is a public health crisis. There's a gap between patients who have OUD and those receiving treatment, and that's where we all can do something about it. Buprenorphine can be safely initiated, and linkage, hopefully, to the outpatient buprenorphine is prescribed, but not mandatory. It should not prevent you from initiating the buprenorphine. So what about the X-waiver? Do I need an X-waiver? So the X-waiver is actually not needed when you're prescribing buprenorphine for analgesia. So any prescriber can prescribe buprenorphine essentially for analgesia, especially when you're prescribing the microgram doses that Dr. Issa was talking about. You can also prescribe with the milligram doses, just sometimes you need to, in order to, for the pharmacy to understand, it's important to probably write for analgesia on the prescription. And then in prior, you still technically need an X-waiver when you're prescribing buprenorphine for opioid use disorder, but there's been changes. So initially the Data Act of 2000, and I want to give courtesy to Dr. Sudhir Portro for the slide, but it permitted qualified physicians to treat opioid addiction with the scheduled drugs. We required 8 hours of training for physicians and 24 hours for advanced practitioners. So the DA then kind of puts this X in front of your usual DA license to prescribe those milligram doses of buprenorphine for opioid use disorder. You would apply to SAMHSA to complete the waiver process. And then during this, the provider also had to have a capacity to provide directly by referral or in another appropriate manner counseling or other appropriate ancillary services. But that changed. So in April 2021, the HHS removed some of the X-waiver barriers. So you still technically need an X-waiver, but you don't have to actually have some of those requirements. So you no longer, so for physicians treating up to 30 patients, it no longer requires the completing the 8 hours of training certification. So not that we're advocating for people to just get this without having training, but you don't have to actually have proof that you've done this certification of the 8 hours. And it no longer requires the capacity to provide that counseling and ancillary services. So you can essentially do this by applying for a notice of intent. So that's a waiver. So the NOI, you apply for this NOI that essentially says you're treating less than these 30 patients, and it's kind of waiving those training requirements as well as that mandatory need for the ancillary services. This is one way to help alleviate, remove those barriers to prescribing. And so should our anesthesia and pain trainees get X-waivers? There's talk, should this be mandatory? Should it be mandatory in pain fellowships? We talked earlier about the National Academy of Medicine. Should it actually be mandatory? So although you don't technically need the X-waiver, it does make things easier. But I would recommend for all of us, on here to get trained and consider using buprenorphine when appropriate. And that is it. So I'm going to stop sharing, and we will see what questions there are. So Dr. Issa, if you want to come back.
Okay, I'm back. Yeah.
One of the first questions is regarding induction. Would you always start with the same low dose of 2 milligrams and titrate, regardless of the patient's prior total MME?
My answer is yes, in kind of a preserved way, but I'd say about 80 to 90% of my patients, yes. And the main reason for this is if the patient is not in full-blown withdrawals. So again, Dr. Kohan kind of mentioned the cows, which is a really nice way of trying to see, instead of just subjectively asking patients, oh, tell me about your withdrawal symptoms, or especially if we're doing home inductions and patients are not sure if they're really having withdrawal symptoms or not. And some of them, because the withdrawal symptoms are what? Basically, your sympathetic system is activated, right? So everything is running fast. Your blood pressure, your pulse, you're sweating, you're lacrimating, all the fluids are running fast. You have diarrhea, things like that. Anxiety can cause that. And patients going through this huge transition, especially if they've been on opiates for a long period of time, they're going to be anxious. And a lot of times the anxiety can look, especially if they become overtly anxious, can look like withdrawal symptoms. So they think, oh, within 2 hours, 3 hours, 4 hours, oh, I have withdrawal symptoms, let me take it. If I give a high dose, let's say 8 milligrams of Suboxone, and they're really not in full-blown withdrawals, they're going to go into full-blown withdrawals. And if you see a patient going through full-blown withdrawals, we used to do office inductions all the time, and I'll tell you, it's horrible. I mean, when you say like sick as a dog, this is basically it. And to the point that I've had patients basically get so scared that they went to the emergency room. So for that reason, it's always better to start lower than higher. So I always say, just start with the 2 milligrams, like we talked about briefly, is start with the 2 milligrams, see how you do within an hour or two. If you're still having withdrawal symptoms, it's not better, then you can take another 2 milligrams. Wait for an hour or two. If it's not better, take another 2 milligrams. So it's always better that way to build it up slowly, rather than starting too high and then, having significant withdrawal symptoms or things like that.
And then another question, I think, for you would be, how do we work out dose equivalent with buprenorphine when using as a substitution? Any difference in the older patients? And then for an example, like tramadol or tapentadol.
Yeah, that's a good question. And here, from what I understand is, if we're substitute from what we're talking about is like if we're converting from a full agonist or even another medication like tramadol or tapentadol, is that my understanding to be buprenorphine, or did you understand something different, Lynn, with the question?
I think
Okay.
I'm not sure. Maybe they said yes.
Yes. Okay. Yeah. So I mean, full agonist opioids are a little bit different than, for example, tramadol or tapentadol. They have other functions. For example, tramadol, I think of it basically as more of an SNRI than even an opioid. It's got a weak opioid agonist, but it's more of an SNRI. Tapentadol is, has norepinephrine reuptake inhibition, plus, of course, the opioid agonist effect. So these medications are a little bit different. They've got, their own advantages and disadvantages, but I think for a certain group of patients, they're really good and they have low abuse potential in most patients. So it's not one of those that if I see a patient like this, I jump into buprenorphine right away. Usually full agonist opioids are the ones that you think, especially if it's a high dose, they have high tolerance, hyperalgesia. Those are the ones I think more of switching them to buprenorphine. There's really nothing, there's no equivalency. And I think, there's multiple organizations tried to find that equivalency of buprenorphine and morphine mill equivalent and things like that, and they failed. I know, for example, here in Massachusetts, the PDMP, the Prescription Drug Monitoring Program, they come up with these reports every year about how much you prescribe. And I prescribe most of my patients, they're only on buprenorphine, not a lot of full agonist opioids. And initially they were doing these morphine mill equivalent, and then they stopped because there's just no evidence to it. When I mentioned earlier, when I went through the slides and I said buprenorphine is 30 to 40 times as strong as morphine, this is more of an affinity perspective. They really bind very strongly to the opioid, to the mu opioid receptors more than a true strength. And we haven't really found that good equivalency between the full agonist opioids, even harder with other medications like tramadol and tapentadol. So to kind of like think about it, So for example, if it's the transdermal buprenorphine, my take is usually if someone is on 30 morphine milliequivalent or less, I start them at a lower dose, like 5 microgram of butrans patch. If they're on higher than 30, I start on 10. Same thing with Belbuca. My cutoff point is about 30 morphine milliequivalent. But that's, again, arbitrary. There isn't really good evidence to it. There's some research showing that that's considered lower than others. But again, everyone is dependent on their comfort levels in regards to that equivalency.
Great. Then there's a question about for larger spine cases, we often use single dose IV methadone. Are there recommendations for when you might combine methadone or buprenorphine? Is it safe to use standard doses, or is it best to use lower doses or even stick to shorter acting like fentanyl? I mean, I think, buprenorphine is in itself long acting. So I think in that case, I'd probably stick to the shorter acting type medications, because you already have the patient's long acting medication on board. So I think there'd be less of a compelling reason to have to use the IV methadone in that case, for that spine case. Someone else is asking about, in the outpatient setting, should we start buprenorphine sooner in our chronic pain patients before they get to large MMEs, or maybe even start off with this medication in those patients with inoperable cancer-related pain or not interested in procedures, for example? What criteria do you use?
Yeah, so this is really, there's a big push right now in a lot of practices to consider buprenorphine as an initial drug rather than considering it as a second or third drug. And I'm an advocate of that. It's like we saw, it's as equivalent in its potency to a lot of other opioids. It's durable, it works well. There's really no need to start patients now. I feel if you feel that a patient is appropriate for opioid therapy, they've kind of gone through the ladder and a lot of other treatments failed, then I think it makes more sense to start. And this is what I do in my practice. I start them on the analgesic forms like butrans patch or Belbuca, rather than going to a full agonist opioid. And the same applies to just your question of like, why wait until if someone is already on a full agonist opioid and you feel that they've gone to 50 morphine milliequivalent or even 90 morphine milliequivalent and they're still showing signs of tolerance or just poor efficacy. There's no need to continue that. I think at that point, switch to buprenorphine rather than continuing to up-titrate the dosage.
And so I'm just going to skip to the chat for a second because I kind of think it relates. People are asking about situations with insurance. When we try to prescribe buprenorphine, insurance told us patients have to have failed oxy, hydrocodone. And so how do you kind of get the pre-authorization?
Yeah. And that's a really good question. It's it is tricky, right? Insurances, whether we like it or not, they dictate a lot of things that we do. I'll say that they're much better now than they used to be, and a lot of them will approve the analgesic forms, which is the butrans patch or the buprenorphine patch or the buprenorphine buccal films. They'll approve them without having to go through the whole dilemma of different full agonist opioids. So they're much better in that. If they don't, I think there's a good case, and I always kind of argue with them. I'm like, you know what? You're talking about a much safer drug that has similar efficacy to these medications with limited tolerance. And truthfully, when I write this down to them, and then a lot of times I'm so used to writing these appeal letters, 95% of times they approve it because there's a really good case that you can make with buprenorphine. The sublingual form, and this is the one that, I use higher dosage, especially if someone is transitioning from full agonist opioid, high dose full agonist opioid to sublingual forms like Suboxone or things like that. That's a little bit trickier because they do want to see the diagnosis of opioid use disorder. What I've done so far is I explain, because if you look at the opioid use disorder criteria, there's 12 criteria basically, and tolerance, withdrawals are criteria from them, although they say that if you look at the DSM, they say that you should exclude prescription opioids from that. But how I say it is, these patients are showing signs of tolerance, signs of withdrawals, and this and that. And if there are other signs that I see of opioid use disorder, so I put these criteria in without saying that they meet the criterion, without saying like opioid use disorder. And a lot of times they get approved by that too. So there's always ways that over years you learn how to negotiate with insurances to get them approved. But thankfully, we've been successful in most of these cases.
Is the buprenorphine started at small dose with their prior opioid regimen or solo, and then tapering the opioids over what time? Is the goal just to be on buprenorphine, and then if stopped, they cause withdrawal? So what is the next step? Keep until the source of their pain subsides.
So I think there's many questions here. Yeah, so I think the first part is similar to what we talked about initially, which is, the dosage of the buprenorphine. Do we start, is it dependent on their previous opioid regimen? And we kind of answered that previously. My experience has been, it's always better to start at a lower dose than a higher dose. Mm-hmm. And it's, just because of the risk of precipitated withdrawals, and just up titrate slowly. Or maybe here they're also tapering the opiates over time. So here I think he's talking also, or the question is also about microdosing, which has been a very common thing. Do you want to talk about this?
So yeah, I mean, there are some methods where you could do microdosing, where you can kind of taper them, so you can actually initiate the buprenorphine at really small, like 0.25 and then 0.5, and kind of go up on the buprenorphine as you're kind of slowly coming down on the opioids. So there are some methods to do that. Kind of, I don't think there's a discrete period of time. You kind of have to just monitor the patients to see how they do. I'm not sure is the goal to just be on buprenorphine. I'm not sure if this is talking about in the acute setting. Ideally, so buprenorphine is part of a treatment for opioid use disorder. So, and saying, I don't know if this means like then if you just stop it, like if they don't have linkage, but the buprenorphine has a longer half-life, and so it's not necessarily like they're suddenly just going to go into acute withdrawal. In the same way, if you gave them oxycodone or Dilaudid in the post-operative period, the half-life is actually longer, so it's going to potentially lessen that risk of withdrawal. But ideally, if there's someone who has opioid use disorder and acute pain, the acute pain resolves. But ideally, you want them to stay on the buprenorphine for treatment of their OUD. So that's where, hopefully you can get that linkage to the outpatient provider, because that's the most beneficial in the long run. I'm not sure if I answered that question or the way it was intended, but
yeah, I think that's what it is. You're right.
So sort of just the questions are coming in different areas. So thoughts on legal implication risk of anesthesia, pain, or non-psych or addiction fellowship trained, for that matter, physicians treating OUD without actually having addiction medicine background training. I mean, we can try both. I mean, I think there's a lot of people, right? Internal medicine doctors. There's a lot of people who aren't fellowship trained in addiction medicine. And I think if you're only confined to addiction medicine specialists, there'd be even greater barriers to treating this patient population. Dr. Issa, what are your thoughts on that?
I completely agree. I mean, even when I did my addiction fellowship, there was like 2, non-psychiatrists that did it. There's other forms of doing, addiction training. The biggest thing, like we talked about, barriers to buprenorphine therapy is, kind of the physician's fear of prescribing. And that's always been a huge thing. If you look at even people who have finished their training as compared to our prescribing, it's an extremely small number that actually prescribe as compared to those. And the main idea is like just physicians are scared of doing it. So it's a huge barrier, and a lot of organizations recognize that. And that was one of the biggest reasons about why Dr. Kohan kind of spoke about this waiver exception, kind of taken out, even you don't even have to do X waiver, and you can treat up to 30 patients. So there's a huge push right now to get as many people as possible to prescribe it. So this implications of risks or things like that, they're extremely low, truthfully. And I get involved in a lot of legal cases that look at buprenorphine and things like that. And truthfully, I've never seen any legal case that says, you know what, oh, this is someone that is prescribing buprenorphine the right way, and for patients with this and that, and we're going to go after him because he did it. It never happens. If anything, we want more people to be able to prescribe it, more people to get, to get this medication to whoever needs it. So my answer to that is yes. It's a fear, it's a true fear, but it's really a non-existent fear, and providers should feel much more comfortable prescribing it and knowing more about it, because I think it's a savior. It's something that can save and help at the same time.
You think about it, I mean, there's so many more barriers to prescribing buprenorphine, which is safer. Right, but everyone can prescribe opioids.
Correct.
There's like more legal implications to just prescribing opioids than treating, patients with opioid use disorder.
Correct.
We just have 3 minutes left. There's another question. Any rough estimate of sublingual to IV conversion?
I don't know that answer, Lynn. I don't know if you know that one or.
Yeah, there is, and I didn't have it in my slides, there is kind of a chart that does kind of give a rough estimate that I'm not remembering the numbers off the top of my head, but I'm kind of weary of using those as direct conversions anyway, because, I think there's some variability. I don't really know if anyone truly knows an exact conversion. Even our typical standard opioid conversions, right, like are not super accurate.
That's true.
I think the questions is just some last few things. Because this was the last. So on behalf of ASRA, Pain Medicine, the APPD, we just want to thank everyone. Thank you very much, Dr. Issa, for being on tonight and for all your expertise. And thank you to all the participants who joined. This is the last Hot Topics of this academic year. So starting soon on another academic year. And the next Azure Pain Medicine Hot Topics webinar will take place on August 2nd. And we'll focus on when to order and how to interpret imaging and pain medicine. We hope to see you there, and thank you all so much.
Thank you all. Good night.
Thank you.